Good morning, everyone, and can I welcome members, invited guests, officers, and any members of the public to the meeting of the Assembly Health Committee this morning. Today's meeting is to gather evidence for the committee's investigation on access to healthcare for trans and gender diverse people. Trans and gender diverse people in London and across the country have poorer health outcomes and health status, both physical and mental, than the population whose gender identity is the same as the sex they were assigned at birth. This is linked to the direct and indirect effects of the daily inequality which they experience. Today, we look to identify key areas where improvements can be made to reduce inequality and improve the overall healthcare experience. We encourage anyone taking part in the discussion on social media to use the hashtag #AssemblyHealth. We have a few short items of formal business to go through first. And can I ask our clerk, Diane Richards, to confirm any apologies for today's meeting?
Thank you, Chair. No apologies have been received for today's meeting.
Thank you very much. And can I ask members to note the list of offices set out at item 2 of the agenda, and also ask if members have any other interests to declare? Thank you. Can I ask the committee to confirm the minutes of the meeting held on the 18th of October 2021?
Confirmed.
Thank you. And can I ask members to note the completed and outstanding actions arising from previous meetings of the committee?
Noted.
Excellent. Sorry very much. And can I ask members to note the response from the Mayor to the committee's letter on managing the ongoing impact of COVID-19 in London?
Noted.
Thank you. So that brings us to today's main item, and I'd like to extend a warm welcome to our guests here in the chamber. We have Ryan Smith, who is a Pride in Practice Manager for London and the South East, part of the LGBT Foundation. Dr. Alison May Burner, Specialist Registrar in Gender Identity at the Gender Identity Clinic in the Tavistock and Portman NHS Foundation Trust. And Dr. Camilla Kamarudin, GP in Gender Health Care, GIC, Tavistock and Portman NHS Trust, and East of England Gender Service. Welcome to all three of you here in the chamber with us. And virtually online, we have Rico Jacob Chase, who is Director of Transactual UK, and Michelle Ross, who is the founder of Clinic Q. Thank you, both of you online, for joining us. So to help us get started, I thought it would be useful just to read out the Stonewall definition of the term trans, which is an umbrella term to describe people whose gender is not the same as or does not sit comfortably with the sex they were assigned at birth. Trans people may describe themselves using one or more of a wide variety of terms. In this meeting and in the questions we've prepared, we've generally used the phrasing trans and gender diverse to include that wide range of people who can experience health inequalities as a result of their gender identity. And this includes, but is not limited to, trans women, trans men, people who are non-binary, and people who are agender. We recognise that under this term of trans and gender diverse, there are many different people with varying identities and each with their own experiences. It's also important to recognise at this point that gender identity is just one of a number of characteristics, such as ethnicity, disability, or income, that can intersect and have a bearing on people's health outcomes. Now, I'd like now to give an opportunity for each of our guests to introduce themselves, briefly stating who you are, what organisation you work for, and what you specialise in. But just to start with, I was going to also ask the committee to introduce ourselves and also to share our pronouns. So I'll start. I'm Caroline Russell. I'm chair of the Assembly Health Committee, and my pronouns are she, her.
Yeah, I'm Emma Best. I'm vice chair of the Health Committee, and my pronouns are she, her.
I'm Andrew Boff, a Conservative member of the Health Committee, and my pronouns are he, him.
Sharani, I'm the London Assembly member for Brenton Harrow and member of the committee, and my pronouns are he and him.
I'm Dr. Oncologists, a GP by background, but now I represent Ealing and Hillingdon, and my pronouns are he and him.
Thank you very much. So now if we can start with people who are online. So Rico, if you'd just like to briefly introduce the organisation that you are representing and Your pronouns are on my screen, but if you could introduce yourself fully, that would be great.
Yeah, of course. Rico Jacob Chase, my pronouns are he, him. I'm a black trans guy. I'm a director at Transgender UK CIC. So Transgender UK advocates, informs and empowers members of the trans and non-binary community. We have three main pillars that we do that, legislative reform, healthcare and media relations. Lovely to meet you.
Thank you very much. And could I now invite Michelle to do the same?
Yeah, sure. I'm Michelle Ross, and my pronouns are she and they. I'm the founder of Clinic Here. I'm also a psychotherapist, and I've been a psychotherapist for 34 years, mostly involved in well-being and sexual health and HIV. Clinic Here is very much an holistic service, and we are in partnership with King's College Hospital, and we have 14 therapists.
Thank you. And now moving into the chamber, Camilla.
Hello, hi, good morning. My name is Dr. Camilla Kamarudin. I am a trans GP and I am working in gender healthcare at Tavistock Portland NHS Trust and also East of England Gender Health Services. I advocate for better healthcare for trans people and better human rights, and I am also a board member at Spectra London and a trustee with LTT Cancer, LGBT organisation for LGBT people affected by cancer, and I also work on a voluntary basis with transsexual, and yeah.
Thank you very much. And Alison.
My name is Dr. Alison May-Berner. I'm a specialty registrar in medical oncology and a specialty doctor in gender identity. I've worked at the GIC in London for the last 5 years, and aside from my clinical work there, seeing patients with and without cancer, I've also undertaken a number of research projects around LGBTQ cancer care and trans cancer care specifically, in particular looking at cervical screening and also the training that healthcare professionals have. My pronouns are she and her. I'm a cisgender woman, and for that reason, because of my lack of lived experience, I'll be quite keen today to let other members of the panel speak before I do, because I'm aware that I don't come from that perspective.
Thank you. And Ryan.
Hi everyone, my name's Ryan Smith and I work for the LGBT Foundation. I am the Pride in Practice Manager for London and the South East, and Pride in Practice is a programme that's now around 10 years old, and it aims to deliver training, assessment, support and accreditation to primary care services to make them more LGBT inclusive, and my specific specialism is in training and education facilitation.
Thank you very much. So moving on to our questions. We're going to be going into everything in sort of detail as we go through the sort of various stages of the meeting. But just as an opening question, can you each outline one kind of main health concern experienced by trans and gender diverse people when accessing general NHS services? And I'll start with Rico online.
I would say lack of non-binary awareness, use of pronouns. From what I hear, trans and non-binary people are not part of any training available, so therefore even elective training, the medical practitioner has to take it upon themselves in order to educate themselves in the trans and non-binary community. But as we all know, Section 28 removed the LGBT people from the curriculum, so therefore the onus should necessarily be on the individual in order to access information. It should be on the educational, people providing education in order to bridge that gap and to help the community that we're aiming to serve.
Thank you. Michelle, do you want to add?
Yeah.
I realise there's lots of issues, but yes, if you can outline one that feels important.
Yeah, I think I heard you say something about barriers in accessing services in the NHS. Is that correct?
The main concerns, health concerns that people have.
Oh, there's so many, and I'll try to stick to the main. But and I think a bit like Rico was saying, that there is a real difficulty, and I do mean barriers, in accessing all NHS services for trans people, because there's no really recording of data, no non-binary, trans, transmasculine, transfeminine at all throughout the NHS, except in something called the HIV and AIDS reporting system. That is the only service that actually records trans people's identity. And that only started in 2017 because of the work we did with Clinic Q with Public Health England and the NHS. So there's a lot of barriers from general health, including GPs, and throughout any health services in the NHS. So I think it's most, but obviously we're going to touch on the gender care aspect as we go along.
Thank you. So in the room, we'll go for Ryan next.
Okay, thank you. I would say the biggest sort of barrier, difficulty, I'm coming at a perspective of primary healthcare, and primary means first. So for a lot of trans people or gender diverse people, their first point of call will be going to their GP. And there's that saying of you can only make a first impression once. And if that first impression is bad, or they feel like their GP doesn't understand or can support them, they're instantly going to lose faith in NHS services, and that can lead them to not talk about what their needs are, not talk about their health needs, and instantly lose faith in the service. So I'd say confidence and understanding, training, like Rico said, understanding the different issues and identities and language in order to then pass that confidence on to the patients that seek healthcare.
Thank you. Alison, do you want to come in after Camilla? Yeah, Camilla.
Yes. Trans people face multiple barriers to healthcare in the NHS. There is an urgent need to address the barriers that trans people face and to improve the health inequalities. Primary care are often the first point of contact for many trans people when assessing healthcare. So, to me, primary care is a key to improved healthcare and provide an inclusive, person-centered care to trans people. The waiting time is incredibly long. It takes about 3 to 4 hours before trans people can be referred or can be seen at a GIC. And then once they've been seen, there'll probably be another a year's wait before they can start hormone treatment. So it is about 4 years before they can have access to hormone treatment. And at the moment, there are 20,000 trans people on the waiting list. So the waiting list to me is unacceptable. There are no other disciplinary no other departments can think in that has such a long waiting list. And primary care can help to improve this waiting list.
Thank you. And Camilla, sorry. I've completely... Alison, sorry, I lost your name. I can't read. The writing is far too small to read across the chamber.
So I think the thing that I would like to raise, that was something mentioned at a meeting held by LGBT Consortium here last week, is around intersectionality and the extra barriers that can be caused by intersectional identities for trans people accessing healthcare. There can be a perception for those who haven't received training as clinicians that healthcare for trans people is more difficult to deliver, and then when that person has an intersectional identity, it becomes perceived as even more difficult. And the barriers are certainly compounded. So I'm thinking about, we've got a large proportion of the trans population who also have a disability, or are perhaps from backgrounds which are less affluent, and actually it's really easy to take for granted how education or affluence can really improve that access to healthcare, a choice to go privately if something's taking too long, for example, access to healthcare where you live. So I think those kind of intersectionalities are something that really needs to be addressed.
Thank you. Well, that's a really helpful introduction to the landscape that we're looking at. I've got a question now for Rico and for Ryan, which is, do you think that NHS is failing some trans and gender diverse people in terms of providing general healthcare and support? And what do you believe are the underlying reasons behind this, if so? So I'll go to Rico online first.
Putting it politely, you have a lot of work to do. When it comes to healthcare for trans people, we have something which we call trans broken arm syndrome. So instead of actually focusing on the fact that the person's got a broken arm, the medical practitioner will say, is it anything to do with the fact that you're on hormones? So no, it's nothing to do with hormones, the fact that you've actually got a broken arm. There actually is an instance that was we collated from one of our transaction reports, where an individual had cancer, blood cancer, and they accredited the thickening of the blood to do the testosterone. The person's been taking testosterone for about 4 or 5 years. The change in my well-being something to do with my hormones. So I would say that's one instance. Raising awareness. There's significantly larger resources on how to use not trans non-binary pronouns, just non-binary pronouns, neo-pronouns. Other administrations, the Welsh government actually has a lot of resources in terms of gender care. So other administrations have actually kind of bridged that gap. And effectively raising awareness that trans non-binary people aren't new. There's a large history of us, and we were removed as part of colonialism. I think that's a really important point to make. And Section 28 hasn't really helped that. So when you're speaking to a medical practitioner, you're not the new TikTok trend. You're actually a human being, and a human being that they're, putting it politely, legally obligated to offer high quality care to. And that's an important point.
Thank you. Ryan.
Yeah, just off the back of that, Rico, I think it's really important to know and hear when we talk about intersectionality. We very much like to put people in boxes and say, well, that's a race matter, that's a disability matter, that's a trans matter, but actually they're all human rights, and you can't pit certain characteristics against another or say that matters more. It's all about bringing them up together, and there's certain steps that need to be done to make sure all characteristics have equal outcomes. From a survey, we did a patient survey this year. It's not formally out in the public yet, but will be next year. But 49% of our trans respondents felt that GPs did not meet their health needs. So basically half. So, I mean, the statistic speaks for itself. And 18% felt directly discriminated by GP practices. So, and just looking at some qualitative data here, patient quotes. I've got a quote here from a patient saying, staff not believing I'm the patient they're calling to come in the surgery because I don't match their expectations against my name. Requests for health screening and vaccinations I'm eligible for are therefore being ignored. And I was training a GP practice the other day, and they had an incident where they called up a patient. They had a seemingly female name, and they are female on their records, but the person that called recognised a male voice, and therefore would not speak to the patient and thought they were lying about who they are and refused to speak to them. And this patient wanted to talk about their healthcare and therefore couldn't. And that was just yesterday in a training session, and that sort of thing comes up all the time. And I would say one of the biggest things is fear. Fear of getting it wrong, fear of offending, fear of not doing the right thing. And it's just creating a bit of anxiety that is then unfortunately passed on to the patients where it shouldn't be.
Yeah. Oh, that was brilliant. Caroline, could I just comment?
Yes, of course. Please.
Okay. So I mentioned Clinic Q. We're an holistic service. We're a trans organisation by trans people for trans people. And our partnership at King's is in primary care around sexual health and holistic well-being. And to pick up on GPs, there are some fantastic GPs are really keen to improve things. However, we get patients, clients every day wanting us to do either hormone injections. They bring the hormones and get it injected because the GP will prescribe it maybe, but the GP will not inject it. They will not administer that injection. Also, people are told that they won't be prescribed hormones without waiting 5 years for a medical diagnosis, which is under psychiatry usually. And the impact on all these issues, all these barriers, are profound on mental health. really.
Yeah.
Also, a simple blood test for hormone levels. Most GPs will not do those. Some people have to travel miles out of their area to come to Clinic Q to get that simple hormone test, which is then given them at a later date, a few days later. But, you know, things need to change. People need to access local services for something like injections, for something like hormone levels and others from an informed GP practice. They shouldn't be turned away and sent miles away.
Yep, yep. Well, and it seems it's both everyday healthcare as well as healthcare that's related specifically to being trans. Alison.
I just want to come in with one point that I think feeds into this, and it's a bit of an elephant in the room, in that one of the reasons, and I'm certainly not saying the case in all reasons, that perhaps some GPs won't provide what we at the GIC or elsewhere are asking them to provide, is a fear of getting it wrong and a fear of litigation or action as a result of that, because they feel they lack education, which is great that Pride in Practice are addressing that, but they also fear that actually when push comes to shove, that won't matter, and that the GMC or whoever else will come after them. They aren't made to feel safe in the decisions they make around trans healthcare in the same way they are for other things, because trans healthcare has become so politicised. And I think when I do training, you can sense that fear of getting it wrong, is that if I'd just rather not be involved, because if I get this wrong, I'm going to lose my licence.
Yep. Which is absolutely devastating that people feel that fear. Camilla?
Yeah, I'm a GP myself, so I can probably give a bit of an insight into how GPs work. I think one of the barriers is that, when I see a patient, sometimes I do not know whether the patient is trans or not, so that makes it difficult because there's no data, there's nothing to document that the patient is trans. All you see is a name, date of birth kind of thing, and because I know my patients, so so I know some of them are trans, but not all, So the lack of data identification in general practice is one of the main barriers. I mean, I tried very hard to introduce this trans status monitoring in general practice, but it's the system that's failing us, and because there is no how we work in general practice is that we use read codes to identify certain things, like we use read codes to identify patients diabetic, for example, so we use diabetes mellitus, this kind of thing, as a problem title, so we can identify the people who has diabetes. But for trans people, there is no read code. There is there are old read codes like transsexual, we don't use those anymore. But there are no read codes actually to say that you are trans man or trans woman or trans feminine or trans masculine. So it's very so that actually is very difficult for a GP to provide person-centered care for the patient. So the patient rings up, kind of thing, that we have no knowledge, that the patient is trans or not. And yeah, I mean, yes, I can echo what actually Alison is saying. There's a lot of fear from GPs to provide the care that they need. I think in my knowledge, in my experience, I think most GPs, I think the majority of GPs want to help trans people, but sometimes they don't know how to help them. I think that is the main, a main barrier. And yes, the GMC have done some improvements in the last year. They have provided guidelines for shared prescribing, for example, and the guidelines are meant actually to protect those GPs who wants to continue prescribing shared care prescribing under bridging prescriptions. So, and it is now not. I mean, GPs are able to prescribe now for bridging prescriptions, and not doing anything, it is unacceptable. So it is already in the GMC guidelines, And yeah, quite right. I mean, there's lack of education among the GPs. For example, like even before I started to work in gender identity clinic, I mean, I thought that gender healthcare is complex, and but it is not. It is not as complex as what a lot of my colleagues thought. And and I have started to do teaching to general GP trainees, and yeah, and then when I told them that how about hormonal treatment, yes, and then they were so like, oh God, it is really not as complex as we thought, because we are been using those medications, we are been using those hormones, and then we have the knowledge and the capability of prescribing. It's just overcoming the mindset, overcoming the barriers, of thinking that it is complex, but it is not. And so, I mean, yeah, it is. I mean, I'm going around to do all this teaching, but out of my own time, so it's quite difficult for me to actually to do more, and yes, I also have a full-time job as well. So I can so much I can do. So, but there are also a lot of my colleagues, a lot of my GP colleagues who are actually very keen and really willing to actually to do more training and to do more teaching. And also there's a lot of other organizations, for example, Transsexual, Pride in Practice, and LTT Cancer. We're all doing a lot of teaching and education in healthcare, in primary care.
That's a really useful point to move on to our next section, which is about attitudes, awareness, education, training and communication of clinical and non-clinical health workforce. And
can I come in before you move on to the next section?
Yes, of course. And then I was going to bring in Krupesh.
Thank you. I was delighted to hear the comments of my two medical colleagues here, because for a moment I thought I was on trial here. In a sense, there was no GP to put up a GP perspective, right? Okay, and I think the real issue here we have is that referrals to the gender identity clinics have a huge waiting list, right? And I understand that patients now referred in 2017 are now being set appointments, right? And of course, this is a very area of expertise, right? Okay, and normal shared care protocols you refer to that is you have a consultant on site who's seeing patients regularly, and you agree with protocol. How do you think, right, that the NHS can respond, right, when we have a 4-year waiting list, right, for the first appointment, right? And the challenges for general practice, of course, is that the average GP doesn't have the expertise, right, or doesn't feel the confidence, right, to be prescribing drugs in those ranges, right, okay, which are outside. And one of the good guidelines of the GMC is that you shouldn't practice medicine outside your safety guidelines. I shouldn't be doing something which I feel uncomfortable with. So given that we have those constraints, right, how can you justify the NHS giving a 4-year waiting list, right, for the first appointment, right, okay? And yet we have a 2-tier system, right? Those people who are affluent can access those same consultants to the private care pathway. So there's an inequality there, right? What's your response to that, please?
There is definitely an inequality here. There is like 3 to 4 years waiting list we seen at GIC. And to me, the only thing that could actually to overcome this long waiting list is to ensure that trans health is part of the medical curriculum in the doctor's training. Yeah, and so, I mean, we've all been taught about lots of things in when we are medical school, but we never really thought about LGBT health or trans health. And yeah, and then we have thought about certain medical conditions, which is even more rare, and then the less incidence of those diseases than trans people. So. Yeah, I mean, I struggle to actually to understand why trans health is not included, or LGBT health as well is not included in the medical curriculum. It's
Dr. Berner?
Got lots of hands up, Onka. Rico was wanting to come in response, and also Alison. So I'll take Rico because they're online, and then Alison in response to you, Onka.
Just to quickly chime in there, so Transaction UK did a survey, Translice, and that was as at this year. So the survey itself, the results came in, and 40% of reports, 40% reported that they refused GP care on the count of being trans on at least one occasion. So that goes to what Michelle was saying, people actually being denied access to healthcare because of their trans identity. When accessing, this is specifically for general health services, as we were discussing earlier, 70% of respondents reported being impacted by transphobia. So when you actually arrive at the surgery, you experience transphobia. And how much do we actually just avoid healthcare in general? There's a statistic here that says 57% of trans people reported avoiding going to the doctor when unwell. So there's various points in which we're either avoiding being discriminated when we actually arrive, or just not actually getting access to the healthcare that we deserve. I think someone mentioned not being offered blood tests. Blood tests are not necessarily seen as anything trans-specific or fancy to get. It's like a basic thing that should be offered, but we're not denied that because of it's for trans-specific healthcare, because it's going to lead to being transitioning. So there's a lot of points there. I wanted to sort of chime in with some statistics there. That was my vote.
Thank you.
Excuse me, have we got those statistics? Is that kind of...
I believe, Dan, do we have the statistics that Rico just mentioned?
In the briefing.
I think they're referred to in the briefing.
That 40% figure as well, is that in the briefing?
I'm more than happy to share them. They're publicly available on our website.
Brilliant, thank you.
That would be fantastic. I'm pretty sure they're actually they're in one of the footnotes in the briefing.
Oh, perhaps, okay.
But Alison, you wanted to come in.
I just wanted to echo what Camilla has said around training and inclusion in the curriculum, because you don't get people wanting to work in gender identity unless they're exposed to that during their training. Currently, it's not mandated for that to be part of the undergraduate curriculum. That's work that actually LGBT Foundation, the parent charity of Pride in Practice, are trying to address. But it is currently, an unfunded, spare time for those of us involved in that committee endeavour, as it is a number of undergraduate and postgraduate lectures that myself and multiple colleagues from charities, GIC, elsewhere deliver, again to try to generate that interest. So we need something to increase the pool of people to explain that actually it's not complicated healthcare, it's actually incredibly rewarding, but you don't attract people unless they're exposed and understand that it's accessible. And secondly, we need the money in order to train people, and it's not that there is a completely two-tier system either. So admittedly our waiting lists are unacceptably long, but actually those of us working in the field understand that we are working at the limit of what we feel we can safely do. I'm sure they won't mind me saying that I've spoken to people involved in the new pilots for gender identity healthcare who are also worked to the bone in those new projects. And even the waiting lists to be seen privately by a gender identity clinician are over 6 months. So it's not like people are leaving the NHS to go to work privately to see people quickly and knowingly provide a two-tier system. I think a lot of people go into doing that went into it originally to provide the aim of seeing people quicker, but actually that's not happening either, because the demand is so high. So I wanted to speak to those things, and I guess I just also wanted to mention that what's happened here in the room already is really demonstrative of what happens across healthcare overall, in that we came here to discuss matters of trans healthcare unrelated to transition, and transition related care has started the bulk of the meeting, and it's because it is hugely important, and the standard with which that is delivered at the moment is not good enough. But time and time again that happens, and actually that's the reason that other healthcare outcomes for trans people suffer, because transition related care comes first, doesn't get tackled, and then other things don't get tackled. So I just wanted to kind of air that into the room.
Ryan, I've registered your hand. Everyone, we do need to be, just in terms of keeping to time with the meeting, we should be in the section that Krupesh was leading on, and then Onka was going to be following up on. So Onka, if you're okay, I'm going to actually hand to Krupesh. And Ryan, did you have an extra point you wanted to make on in relation to Onka?
Just a very small one. It was about the waiting list, and when we deliver training, what we want to train GP practices on is that, okay, you can't change the waiting list. If there's a waiting list, what can you do? But during that time of the wait, do you know local services? Do you know local charities that you can signpost? Do you know about bridging prescriptions? Do you know what you can do to help that trans person during that wait? Because there's lots of things you can do. You can't change the wait, of course, but once we start talking about and sharing local services and organisations like us, like Transgender, like us all here, there's actually a lot of support out there. And if you can't change the waiting list, we just want you to be aware of being able to signpost trans people and still support them rather than going, wait, essentially, and we can't do anything.
Krupesh, just before you start...
we'll hold on. So
You'll
in
hold
the interest
on.
of
Fantastic,
going on.
thank you.
Yeah.
Good teamwork. Krupesh.
No, thank you, Chair, and for your previous answers as well. And I recognise, I think we've focused a lot on transition-related healthcare so far, but I think it is also incredibly important, just reflecting on someone I know in my constituency who's actually going through the process. It's not just the waiting time, but sometimes you get an appointment and then the appointments are moved as well. And it takes someone, you know, it's incredibly distressing for someone even to get to that point to come up and actually try and reach out to get those appointments in the first place, and then to have them moved. I think it's just unacceptable. One of the things I've also found is we spoke about the two-tier system, but there's a whole world of people online who are trying to open up GoFundMe pages, and they're promoting each other's pages so that they can raise money for transition-related treatment as well. So I think it's important we look at the issue. Moving on to attitudes, awareness and education. This one, I think I'll ask Ryan and Camilla maybe to start off on answers on this one, and the other panellists can come in if they have something to add. But can you outline some of the key issues and challenges that emerge for trans and gender diverse people when interacting with the healthcare workforce? Ryan, you want to start?
Okay, yeah. So just a few quotes that I've got from GP practices when I start training with them. So 98%, when we get feedback forms, 98% of those that go through our training feel more confident to talk about trans issues and trans healthcare. And one example was I speak about binding with trans men or non-binary people that might bind their chest, the dangers of binding, how to bind safely. And a doctor looked at me afterwards and said, I had no idea about binding. And I've got a trans male patient, and thank you, because now you've told me about binding, I feel like that's a conversation I want to have. And I always say, instead of feeling anxious or scared to say the wrong thing, you should feel empowered and excited to try and say the right thing, to try to understand your patients and their health needs. And that's particularly what we do in Pride in Practice. And we don't just deliver a training, because sometimes training, it can be a bit tick boxy. Okay, sit them down, do a training session, and everyone suddenly knows everything. But Pride in Practice doesn't work like that. We train, then we assess, we look at policies, we look at attitudes, we look at their confidence, we look at their knowledge and approach, then we support, we tell them what's out there, we signpost, we help them make the changes, we send guides, and then finally we award, so we can recognise their commitment, and then they can put that award in their practice, which then patients can see, and it's a symbol then of, oh, they've gone through a process. And I just want to make that reiteration, because when we talk about training and education, it's great in essence, but are we having the conversations? Are we having the processes and support? And we can spend months with practices to get them where we need them to be, and have many different sessions to train all different parts of staff. Because we've spoken about GPs a lot, but like we've said, reception staff, nurses, and the waiting room environment, having a poster on the wall. Just knowing that having a poster on the wall, we've got our poster here and we always send it to practices that we work with, but just having an LGBT poster on the wall could essentially save someone's life, because someone sat there that is scared to talk about who they are or their health concerns, see that, oh, a practice has a poster on the wall or a leaflet, that means I'm seen, I'm visible, I'm heard, and therefore I might be able to speak about my issue. So again, my training always leads back to building up confidence, and back to my point about not being scared to talk about these things. Talk about these things and get to know your patients and their needs.
Doctor?
Yeah, thank you. Yeah, I just want to quote the Stonewall's LGBT Britain Health Report 2018 that stated 37% of trans people avoided healthcare. So there's a quite high percentage here. Even I myself, as a GP, I have experienced, not a very nice experience with even from another GP. So just imagine. I mean, I'm a GP myself, so much so that I avoided to see him on a Monday and Tuesday. So, and I would see the other GPs on Wednesday, Thursday, and Friday. So if I got something I want to speak to my GP, I have to wait until Wednesday or Thursday or Friday to speak to a GP. So sometimes that's how bad it is for some trans people in joint practice. Yeah, I mean, it's not just about training that I think that we need to emphasize on, and also awareness, but also providing the services, and NHS not able to provide all the services that's available. Like, and for example, we need more trans-specific services for trans people. For example, like psychological access, for trans people. There isn't any, it's very difficult for trans people to access specific trans psychological help, and I think only in Spectra, London, which I'm a board member, that we have started to offer, we have already offered, we have already started the services a long time ago, but we're now expanding it, and we offer psychological help for trans people, and but the demand is just so much. There's only just one services for trans people in London that I can think of. I mean, there are also LGBT Foundation and that can help as well, but LGBT Foundation is like it's just for all over UK. But we need more funding. We need more funding for the community services. The trans-specific community services.
And probably moving on to Rico, I think, because this question is probably more appropriate for you. Can you explain the potential impact for trans and gender diverse people when they experience a discriminatory or negative interaction with a healthcare professional?
I mean, it's gatekeeping, really, isn't it? I mean, if someone is a trans non-binary person living in a binary society, I mean, what are they meant to do? You have to look at the social economic factors that most trans non-binary people live in. Because of a transphobic environment that we live in, that they're receiving hate crime, like traveling, can't get jobs, there's instances of people being made homeless by their landlords. We're 100% in survival mode. So if you ask someone to live in survival mode for 5 years for a first appointment, there's no other service that could be put on, could say there's a 5-year waiting list where that would be seen as appropriate, but for some reason it seems sufficient to sort of offer that to trans and non-binary people. And it's not even until you transition, so you have the first interaction with a medical practitioner. And after the first appointment, it could be another 5 years. So you're asking people to live in survival mode for a 5-year period. And in order to get gender dysphoria diagnosis, you have to live in your assigned gender for a 2-year period, which means the person has to be subjected to the public, the general public, for a 2-year period. In that situation, are we going to survive? I mean, if you could ask yourself, would you be comfortable putting on the clothes from different gender and walk around for 2 years? If you find that nerve-wracking, then you can see what the confidence it takes to be a member of the trans and non-binary community. Putting it politely, I'm sick of going to visuals because we're not surviving. And unfortunately, I was raised in a position of privilege where sex work wasn't normalized. Being a member of the trans and non-binary community is incredibly normalized. Because how on earth is someone who can't get a job going to fund the medical transition? So the gatekeeping for NHS services is directly impacting people's mental health. I think the mental health that Camilla was talking about is necessarily when people say mental health of trans people, they tend to think it's some sort of link to conversion therapy. I know that you weren't saying that, Camilla. But what we're talking about is that because we're experiencing significantly large amounts of transphobia on a daily basis, even just doing basic tasks like shopping, we end up having severe depression, severe anxiety. Me personally, I end up with post-traumatic stress disorder after, not even transphobia, homophobia. I had to really learn how to read and write and eat in a public setting. That's the level of anxiety I have. And unfortunately, my story isn't unique. There's so many of us that in order to survive this environment, a lot of people do turn to sex work in order to pay for the medical bills. So there is a lot of work to be done. And I don't necessarily think a GP fully understands what they're doing to their patient by denying them healthcare.
Krupesh, could I just remind you about that this is about access for everyday health services rather than gender identity services, which is the sort of scope of what we're trying to cover. And I completely get you can't distinguish because the situation in terms of accessing gender identity services is so clearly broken. But what we're trying to get to the bottom of here is that experience of walking into a GP's surgery and what is it that someone experiences, and are there recommendations that we could be making that could actually improve that situation for everyone? And sorry, I can see Michelle indicating online, but I'll hand back to you, Krupesh.
No, if Michelle can we can start off with Michelle to move on to the next question. It's probably something all the panelists can come in on what needs to happen within the NHS, not only to improve the patient experience, but also to deliver better outcomes for trans and gender diverse people.
Yes. I'd like to say some things, if that's okay. Sure. We work, as I said earlier, with King's College Hospital, and we're doing a lot of work in various areas in access to health services and making them much more accessible to trans and non-binary people. Consider this scenario. A trans person that I know personally a couple of years ago had an accident. They were hospitalized. On the day one they entered the hospital, they were mispronoun, misgendered. They were used the wrong. Not only were they recovering from this quite a bad accident for a couple of weeks in hospital, they were also suffering from mental health issues of how they were being treated. And not saying they weren't cared for, but they just kept mispronouncing, they kept misgendering, they kept using the wrong terms completely throughout their whole stay. When they came out, they were physically a lot better, but mental health had deteriorated. And as a psychotherapist, I see that every day in people trying to get therapy from Clinic Q. We have, as I said, 14 therapists, 14 counsellors, and we don't only focus on gender care. We look at the mental health impact of living in a society that doesn't provide services for them. And not only the waiting list for gender care, but actually any other aspects of fear of going, say, for a cervical screening for a trans guy or non-binary people who have a cervix. There's a whole range of issues and barriers that people face, and people know that and then don't access health services when they know that they really need them. There's a really deteriorating health need and a crisis, I would say, within trans communities in accessing NHS services. Now, I work closely with Michael Brady, Dr. Michael Brady, who is the NHS advisor for LGBT health. And I wish he was here today because I know that he'd have a lot to say on these issues. There really needs things to be changed, and training is important, but actually there's much more to training than that. The NHS is huge, and if anybody wants to come and visit our service on a Tuesday, you're welcome to see what we do.
Thank you.
Krupesh, can you see Rico's hand is up?
Sure.
Just, it's difficult to, I'm sorry, for both of you online, we've got a slightly clunky system here. It's difficult to see the little hand, but we're trying.
Not at all. I know that we're short on time, so I'll keep it short and sweet. Another good example of mental health instances of just people, members of the trans non-binary community, just do it themselves. A friend of mine is a student, a second-year student. Whilst doing their degree, started an organisation called Black Trans Foundation that offered therapy. The student managed to get professional therapists, did all the paperwork, so it's officially licensed, and they offered therapy to 30 trans non-binary people. The service sold out in 1 minute.
Yeah.
That's how bad it is. There are a lot of sober gatherings in London where trans non-binary people sort of collate, exchange stories. It's a safe space for everyone to be. That particular service will offer free therapy. So in the social gathering where everyone is probably just sort of having food, there's a free therapist. The community is protecting itself. And if we get to that level of desperation where people, as I mentioned before, are usually under the living wage, are offering services to protect each other, then it really, really indicates the problem that we do have when it comes to healthcare. We're in survival mode. That's what I wanted to say.
Sure.
I think I just want to touch on a couple of points that I think relate a little bit to what Rico is saying. I think that there is a perception more broadly, even outside healthcare, that, oh, it's okay, trans people must be doing okay because there are a few high-profile trans people with good jobs or in the media who are doing okay, and therefore we must be doing all right. But actually that's not true. We're failing a whole bunch of people. I think it was Rico that mentioned an astonishing figure again at the meeting last week, that the average salary of a trans person is less than £17,000. And I think that kind of perception is really out there, and then that creates an additional barrier, and that kind of links to something that I've come across around historical stigma and discrimination that pervades. So there's a perception sometimes when I go out and deliver teaching, it's like, well, actually it's okay because we've got all of these protection laws now, and I'm not transphobic, and I don't know anyone in my practice that's transphobic, and so therefore it's fine. But actually we're still treating patients that lived through being gay being illegal, right? And you know, we're still treating patients that grew up in a time where they wouldn't even dream of mentioning their gender identity. Those are the patients that come to see me with cancer now, you know, and for them to disclose is such a massive thing. So we need to go over and above just creating the patient experience that we create for everyone. We need to go that little bit further. It's not equal care, it's equitable care to make up for the failings that have occurred across time. And then when it comes to specific needs, and Michelle mentioned cervical screening for trans and non-binary people, that's an area I'm particularly interested in. That's a specific healthcare need where there might be particular barriers for trans people. Not all medical professionals are aware of those areas of particular needs. So we did a survey of oncologists, and this was in a broader category. This was just saying, okay, well, how confident are you in the specific needs of LGBTQ patients with cancer? 8% said that they felt confident. There is no other group where that would feel appropriate, that 8% of your clinicians feel confident in managing a healthcare issue, or even knowing what that healthcare issue was. And so that leads slightly out of the thing of experience, but I just wanted to use that figure.
Can I just add what our listener is saying? With that, even within the trans group, there are also some, group of trans people actually facing even worse health inequalities. I'm talking about specifically about the neurodiverse population, and then there's this thinking even among health professionals that think that that neurodiverse people can think, oh, they cannot be trans. So it's like they don't have a gender identity. It's, so it's very, very even more difficult for a neurodiverse people to actually access healthcare, to access help, and very, very little understanding and an awareness about what they need and about but support. There's very, very little support for neurodiverse trans people in the community. And it is very disappointing, and it's also heartbreaking for me to see, this group of people not able to. I mean, it's very difficult for them actually also to access healthcare because they don't communicate as we do. They communicate in different ways, and so we need to adapt about how they communicate, so we need to adapt, and we need to to provide the support that they need. But neurodiverse people, they have a gender identity, and a lot of them wants to be trans. So, but even among healthcare professionals have this, thinking that they cannot be trans, which is absurd.
And for my final question in this section before we move on to Dr. Sahota.
In fact, we'll come back to the chair because I want to bring in Emma and before we move to Onca. But go for your final question, Rupesh.
Yeah, so I think this one's probably best addressed to Ryan, given the work that you do with professionals and training. What do you believe are the reasons, be it attitudinal, cultural or systemic, that can result in clinical and non-clinical employees discriminating against or displaying offensive language to or behaviours to trans and gender diverse people?
Yeah, there's a long list. There's a long list of, why do people discriminate? My passion, my background, my strength is in education and training. So I'm always going to go back to my background is in teaching, and I always believe ignorance is learnt, discrimination is learnt growing up. If we normalise certain relationships, like it's only been put on the curriculum last year that LGBT identities and relationships need to be taught in schools. So especially if you are from a different borough, if you are part of a certain religion or racial group, you might grow up with a certain stigma and not understanding. So again, I'm always going to go back to education and training. In terms of education and training, the barriers that we're facing to get GPs to training, the first point of call, like has been said, is the curriculum. It should be when someone's training to be a doctor or a nurse. I actually spoke to my friend the other week, and she's just qualified to be a nurse. And I said, in your 3.5 years of training, did LGBT issues ever come up? And she said, not once. And she's an ally and she knows about all these issues, but not once in her training. So, because essentially services like ours, Pride in Practice, it's reactive. We're reacting to a problem, we are trying to address that, and we are going to surgeries to try and bridge that gap. But what would be great is if there was a proactive approach where when people are training, they already get that knowledge. Secondly, awareness, knowing that there's a problem. Like we're saying today, there is a problem. And this isn't about demonising or putting down GP practices or GPs or the NHS, because lots of trans patients have wonderful GPs and wonderful experiences, but the statistics speak for themselves, and there is inequality, and that needs to be addressed. The next thing is time. Every single day I am contacting practices. We are currently funded to deliver Pride in Practice to all practices in Lambeth and Lewisham. And let me tell you, there are many practices that just aren't getting back to us or just don't have the time to fit in an hour's training. They just don't have the time. And then finally, it's been said, money. It all comes back to money. Pride in Practice costs money. Practices can purchase Pride in Practice themselves, but often can't afford it. So we'll go to the CCG or ICS or anywhere, basically, we can get funding for an area. So yeah, curriculum, awareness, time and money, I would say, are the main barriers. But in terms of your question, what makes someone have discrimination or ignorance? Yeah, it goes back to being educated, knowing the truth. And we've said about the media, if your only experience of trans people is in the media or the Daily Mail, then they're probably not going to have an open and true understanding of trans identities. So, yeah.
Krupesh, Rico was had their hand up.
I'll just quickly chime in there. When it comes to awareness, a lot of people don't know that trans non-binary people aren't new. I think that's a really, really important point to make. That people tend to think that it's some sort of phase or TikTok craze. It's literally not the case. Trans people, non-binary people existed. It was actually colonialism that actually removed it. And I know everyone keeps talking about colonialism, so I can see people, I can probably guess people in the room are rolling their eyes, but it is an important point to make here. And the reason being is that there were trans non-binary people, the two-spirited people, the Hijari, there was non-binary Egyptian pharaoh, there was non-binary people in the service of Temple of Artemis, non-binary people who were considered divine in Angola. So those are parts of society where they had a role, they had a place, and we have to sort of understand that where we are today, the same way that there's sexism, there's racism, transphobia is also part of that, and a lot of people don't understand that. And I'm not expecting them to, because we're just trying to get the LGBT people in the curriculum. But having that awareness, that point's really needs to be hammered home. You're not going to know because you weren't meant to know. Let's put it that way. I just wanted to chime in and say that.
Can I very quickly say, thank you, Rico. I transitioned 50 years ago. I don't really like the term transition, but most people get it. So yes, you've been around for a lot longer than anybody thinking it's a phase or a little new thing. But also I know a lot of older trans people who live in stealth, who are not out about being trans, don't want to be, and never access health services in all that time. There's an embodied fear, embodied stigma that they walk with every day of being known as trans and accessing health services that are going to discriminate against them. There's a lot of issues. I'm working with King's Older Service as well.
Thank you. I didn't have a follow-up, but I think something has come out in this discussion that I did want to get your views on. And one thing that wasn't really explicitly said in your answers was about interaction and engagement in sort of non-clinical settings as well. So do you feel that when healthcare professionals have someone come to them wanting help and support, that being in a clinical setting is almost a barrier, and what more can be done to maybe increase that engagement between healthcare professionals and the community in a non-clinical setting? Are there ways that you've seen work that can maybe break down some of those barriers? You had your hand up, Dr. Fuller.
Yeah, I just want to touch a little bit on the on the discrimination bit about in general practice. I mean, I would like to think that, as a GP myself, I would like to think that discrimination is not very common in general practice, but probably what is more common are, microaggressions. It's like everyday slights against trans people, which come across as, as equally, devastating for a trans person. And we can, there are some specific examples, like saying, receptionists would tell everybody, would tell someone else, "Oh God, she's a trans, so just be careful about what you say." I mean, this itself is already not very nice for trans people to hear. So it is more about the microaggressions, the everyday slights that actually that's happening in general practice. And this the only way to overcome this is more awareness. And I've been to some unconscious bias training in general practice, but none of them actually touched on LGBT issues. None of them actually touched on trans issues. No, not even a single mention. So this unconscious bias is something that we need to address. I think not only in general practice, but I think in any other organizations. Yeah, that's just the point that I want to say.
Great. Can I say? Okay, great. I think I heard your question right about social situations outside of a clinical place. Well, first of all, I want to mention that Clinicure are having our 7th conference in partnership with King's College Hospital, and we're going to cover all these issues in great detail. So I can send you details about that conference, and you're welcome to come. And it's down in South London where we deliver our services. But we also deliver services online as well for counselling and therapy. Just to say, when we set up Clinic Q, it was from the community, by the community, set in an NHS setting. We've been delivering services for 10 years. So what we do with the waiting area, we switch it up, we make chairs much more available, people sit in groups, talk to each other, make friends, go out for a meal afterwards, bring friends, bring family. Some people play guitar, some people will juggle. This is all in an NHS setting. We provide teas, coffees. Before COVID, we used to provide sandwiches and biscuits. We're now bringing biscuits back. But, that was a real issue. There was a real issue that we had to change that safe environment, that community space within an NHS that people were coming for our services, but also making friends. We had to change that and we had to go by appointment. We're bringing some of that back again. But there's many different ways of interaction, and our conferences are also very social interaction. We have a lot of doctors, we have a lot of clinicians and trans community. Come to it and see. Anyway, there you go.
Looking forward to the invitation. That's it from me.
We've got two other hands up. Are you?
Just two sentences that, again, co-delivered and trans-led work that involves the community is a way to build trust in healthcare. I didn't mention I'm also a trustee of LTT Cancer, and the work of that charity, again, everything is trans-led, co-delivered, and trying to embed things in the community. If it hadn't been for COVID, we would have had a stall all about screening at the Mighty Hoopla conference this year, festival this year. So really embedding that stuff out there is, it is really important.
I'm just going to touch on, so we're talking about, I guess, before someone gets to a practice, what can be done. And I always go back to visibility. So when we work with a practice, we encourage them to put their confidentiality policy on their website that explicitly mentions their trans patients are protected, the Gender Recognition Act, their zero tolerance policy specifically mentioning their things, LGBT mentioned on their website. And what happens more often than not is reputation. When a practice gets a good reputation for dealing with trans people, they will talk to each other. There'll be services that know of certain practices that are more inclusive, and then we see certain practices that do have a higher population of trans patients because that word of mouth has happened. So visibility and reputation, very important.
Thank you. And yes, really, really strong message there from all of you about trans-led services and great ideas. I mean, good things for us to think about and take up in terms of our recommendations about confidentiality policies on websites. There was something else you said just earlier, which was I'm visible, I'm heard, which you said sort of right back at the beginning of Krupesh's questions, but really important points. I just want to, before we move to Onka and your questions, Andrew and Emma, did either of you have any follow-ups on anything we've done so far?
I think there's a more appropriate section for me to cover.
Fantastic, thank you. Onka, over to you.
Thank you. Ryan, this question is to you. Can you provide an overview of the current guidance and training for GPs and other key health professionals with regards to trans and gender diverse people?
As in training that's not through us?
Yes.
No.
Oh, come on. There's JIAS. JIAS have got an online training around these issues. But yeah, I mean, and there's others. We do a lot of work on training as well at NICU, but mainly in
sorry,
NHS.
I thought you meant that it is included in like the curriculum and training. There's lots out there. There's many different charities. I can't name one that does the specific Pride in Practice programme that we do with the awarding and the accreditation and the ongoing support, but there are many out there, and it's difficult because I feel like there shouldn't be necessarily the pressure to be put on an individual GP practice to go and seek that, because that is a lot of work. But then at the same time, there shouldn't necessarily be the pressure for LGBT charities, LGBT individuals to be their own champions and push them to be more inclusive and get the training. There's a list of signposting different services. I'll be happy to share that afterwards, but I'm not going to go through them all now. But I guess what I'm saying is there are a lot of opportunities out there, and again, time is an issue, but there's a lot out there.
Just talking about pride in practice, I mean, what has your experience been? I think you've been working mostly in Lambeth and Lewisham so far. So what has your experience been from that programme of working with GP practices in those two areas?
Once I get them, in terms of we have a conversation, we engage, we get training booked in, absolutely brilliant. It's just so great to have these conversations, and the first thing I say is this process is not about judging. It's not about me testing you or tripping you up. It's a nice safe space, a supportive environment for us to talk about the issues at hand and what we might do to bridge that gap. and not just provide that training, but also to provide the support to get them where they need to be, look at the policies and all of that thing. My barriers have been the practices having the time, like I said before, to fit in a training session. Sometimes they get training afternoons, but it's already booked up. And it's difficult at the minute. We're hearing winter rush, we're hearing next year, we're hearing vaccinations, we're hearing flu jabs, all of this stuff, and it's all relevant, of course. But I always want to say is LGBT healthcare or trans healthcare, it's not separate to those things. It's part of those things. COVID has had a huge effect on the trans community, and winter and homelessness, it all affects the trans community. So sometimes I feel the attitude that it's a separate issue, it's a bit of an extra curriculum thing. Oh, it's a choice, we might do a bit of LGBT training. I want a waiting list. I want practices to be knocking at my door saying, please, please, we need this. But at the minute, it's not quite like that. But when I do get someone trained and get them on the process to being awarded, I've always had a brilliant experience.
I'll come to you now. Just of number of practices in your area, what's been uptake? Has it been 10%, 50%? Or?
So it's around 50% in each borough has been trained. So once we train, we then assess. And once we assess, we give recommendations. So we say wording needs to be changed on these policies. You need to provide evidence that GPs are aware of this type of thing. That process is a bit, how long's a piece of string? Because it could take a practice months to find the time to do that. It's a supported process. We don't just go over to you. And different in Lambeth and Lewisham, but out of that 50%, I'd say we've got around 15 to 20% actually fully awarded.
And how can this programme be rolled out to the rest of London?
Essentially money. So we've had interest from Greenwich, we've had interest from Suffolk, and they really want to get on board, but they're trying to find the right pot, and they're trying to find the right pot of money to fund us. So we're funded currently with Lambeth and Lewisham until March, and we're having conversations with them, how do we extend this funding? Because COVID got in the way, 2021 has been a tough year, so next year we're thinking of this year where we can really just get practices, Pride in Practice awarded. Like I say, I would love the whole of London to be on my turf, to be getting this training. But again, they need to find the money and funding to do that.
And at the moment, the funding comes from the CCGs, or?
It's all different. So CCGs, they might get funding from Public Health England. Sometimes it's individual practices, but not in a funded area. So currently Lambeth and Lewisham are funded by the CCGs until March 2022. But sometimes it is difficult for them to find the funding pots. And again, I want there to be that reiteration of this is vital, this is needed, this shouldn't be, oh, can we afford it here? I want us to be a priority. I want trans people to be a priority on when money is being spent.
Great, okay. Dr. Byrne?
You mentioned that there is also a Royal College of GPs e-learning module, which both myself and Camilla contributed to, but it's not compulsory. Again, it's LGBT health as an optional extra, and it really is a broad brush overview. It doesn't go into detail. And what we need is vertical threading through the curriculum where you cover screening and you discuss all the issues related to trans and non-binary people and screening. It needs to be more in that way.
Thank you. I was going to come to you. I was going to come to you next. Okay.
No, sorry. Yeah, I'm just what Alison just saying. Yeah, that there are e-learning on the RCGP website. But in my experience, if I were to write to a CCG and asking or to a GP practice, can they do one training, kind of thing, and they would say, oh, we want, but we don't have the time, and blah blah blah. And so what I've done is I concentrate on the GP's vocational training scheme, so the future GPs, the young GPs, and they have an afternoon where they have a training. So I wrote to the program directors in London, and and every GP vocational training scheme is interested in inviting me to do teaching, and yes, I've done four, five. Yeah, I only started like a month ago, and I've got another one this afternoon. And but and it's very well received. A lot of the young GPs are very enthusiastic, very engaged. You know, they were telling me, says, "Oh God, this is what we really want. We've not been taught in any medical curriculum." So you know what, I taught them about hormone treatment for trans people, bridging prescriptions, and also we talked a little bit about doing exercise of humanities, about unconscious bias, and talking about barriers to healthcare for trans people. So it's very, very successful. But the only caveat is that, like I'm doing it on my own free time, and I don't know, no one is funding me, and yeah, sometimes I do get some nominal fee from the GP training scheme, but it's very, very nominal, and so it's going to has to be an ongoing process, because this year I would probably able to finish off all the GP vocational training scheme in London, but next year there'll be new GPs, so it's got to be an ongoing process kind of thing, and there are also other my colleagues who want to contribute, who want to be involved, but they also don't have the time.
Okay, look, Suma, thank you. I think that's really helpful. So there's very little education on the undergraduate program, but you're saying there is interest right across London. Are there any modules or any like the RCGP, right, the Royal College of General Practitioners, and also maybe Royal College of Physicians, they run courses. Are there any modules run by the RCGP? Could this be something you could formulate a module which GPs can sign up in terms of the continuing education?
Well, they could be, yeah. But it's all at the moment. It's all just voluntary.
But has any approach been made to the Royal College of General Practitioners to set up a training module for this?
There are also some barriers within the RCGP as well, which I'm not going to go to that route kind of thing. And yes, I have been conversations with Royal College GPs about that we could have funding to introduce GPs to special interest, for example, in trans healthcare. So it is still in the discussion process, and but it's meeting a lot of barriers at the moment. Yeah.
Okay. Could I just alert you? We've got two people online who are wanting to come in on this, and I know it's really difficult to see their hands.
I can't see their hand at all.
Andrew was hoping.
Not difficult. Is I can't see at all.
So Rico had a hand up first, and then Michelle, and also Andrew has indicated as well. Just if we could just let them come in.
Okay, Rico.
Yeah, just to quickly chime in there actually is a GP resource that Transactions pulled together. So Camilla is actually part of one of our healthcare working groups, and that's publicly available information. It's a two-side document, so if you do have a trans patient in front of you, you can just pretty much read it and work out precisely what you can offer. That was created by GPs, but it was also signed off by people in the GP practitioners who haven't actually encountered the trans and non-binary community at all. So it is pretty comprehensive. So I couldn't stress enough that GP training from pride and practice is important, but realistically, putting it politely, there isn't any excuse at this point. The only reason why you wouldn't want to offer healthcare to a trans and non-binary person is because, as you mentioned, you'd have your own personal reservations, whether it's to do with the sort of current legal climate, because you potentially could be transphobic. So we've kind of created an environment where it is easy for trans GP in order to offer healthcare, but the resources are there.
Okay, yeah. And I think, Michelle, do you want to come in?
Hello. Everybody here, Rico, Camilla, Alison, and Pride in Practice, are all working full out, really delivering excellent training, awareness, doing, a lot of trans people are exhausted in what we're doing and delivering this. And quite honestly, it's scratching the surface. No matter what we do, it's still not enough. And it needs to be taken further.
Yes.
Either with all the people here, but I know what we do at Clinical, we're overwhelmed with the need of trans people, definitely. Yeah. And as I say, these are excellent services that everyone should access. The Transsexual and the Camilla and Pride in Practice are doing, but it's not enough. It's got to change quicker. It's got to happen because people are suffering physically and mentally. the deterioration of mental health that we see at Clinic in our counselling services, which are not funded. The 14 therapists work full out. Most of them are qualified. Lots of them are trans and non-binary people. And we see the impact daily, every day.
I'll also quickly chime in when it comes to basic aftercare. There have been some reports when it comes to phalloplasty. I know probably we'll discuss this later, but just specifically when it comes to aftercare, people are being left in acute pain for over a year period. And in that period, therapy or any sort of mental health support wasn't offered. For any surgery, that would be considered bog standard, but for some reason, for trans and non-binary people, it seems to be a bit of a question mark. So yeah, there is a bit of a double standard, unfortunately. So it does need to be addressed.
Andrew, did you want to come in?
Just
I think
very briefly, I just had a question, perhaps Mr. Smith, about the about what training is compulsory for GPs with regard to trans.
As far as I'm aware, none.
None. And
yeah,
is that confirmed by the?
There's optional modules that they can take.
There's options, but
as far as I'm aware, there's none compulsory.
Yeah.
Okay. Okay. Thank you. That's the only question I had on that.
As a GP, I can confirm that there's
nothing.
It's not mandatory training. Yeah.
But there is actually. I will plough a little deeper. There is compulsory training on things like inclusion. Is there? Or I mean.
Sorry, I'm laughing. It's the equality and diversity click a button, get a certificate training you do it every time you join a new NHS trust doesn't even factor in here. It's like it's basic knowledge. It does not delve into these issues. It doesn't cover this in anywhere near the depth that.
So there are training programs for GPs to be inclusive, but you're saying they're not.
Every time,
they don't include trans
every
people.
time as a health professional we join a new NHS trust organisation of any kind, we have to click through a variety of training modules. Often you're not remunerated for the time you do them. You do them very quickly. You do the same one every year or every 6 months, and they are a tick box exercise. They don't delve into any of these issues, and proof that they don't delve into the issues again comes in that survey of oncologists. Massive percentage said, yes, I've done my local equality and diversity training in the last 5 years.
Okay, so it's more monitoring rather than training.
Absolutely, it's to say people are aware of this stuff.
So we can quite confidently say there is no compulsory training on trans issue for GPs.
Yeah.
Thank you very much. Thank you.
Did you have one more?
Yeah. Thank you. So let me. What do you think that the mayor can do to raise awareness and improve education in this area?
Who can start?
Yeah. I mean, given that the mayor has no responsibility for the NHS directly. Okay. Yeah.
Can I start? Yeah. I think the mayor London can provide funding for people like us, people like us who are, people in the community, people like me, Alison, who are the doctors who are involved actively involved in training, awareness, and education. And we need funding basically. And there are community services like private practice, transsexual, and I speak for my charities, Spectra, London, and of course we are together, me and Alison, LCT Cancer. So we need funding because we are all going out there, education, awareness, and but we all. People like me and Alison, we're mostly doing it our own time. There's so much that we can do, but there's so much that we still have to do and we can do.
Before anyone comes in online, just to say that particularly for community organisations that are doing a lot of this incredible work is not just to provide funding, but to provide sustainable funding so that the projects that are done are, everything is embedded. You can train the next person so that actually the community isn't getting burned out, that you can share knowledge, you can upskill people, so it's not the same handful of people. We'll all know, we see each other at all the same events, it's all the same people, and within the communities themselves it's a lot of the same people, to be able to upskill people, to be able to get people involved, and also to provide support for trans people, providing trans services so that their mental health is safeguarded. I hear from a lot of people that work in charities, who work in healthcare, who are trans, that their mental health suffers because of having to hear the stories of others. You take on a certain, that's something that I will never be able to appreciate, but hearing about that and seeing time and again friends who say, actually, I love delivering this service, I really want to do this other great thing that I've been asked to do, but I cannot cope. So actually a level of counselling and therapy and support and that is also really important, and that's not spoken about enough.
Yeah, I think the mayor has a big role in pushing, raising awareness, right, and being champion for this cause, and I think he will be, and he is. But I think the NHS England, the education board, right, has a duty of training. That's what's really responsible for training. Okay, do you think that the government's lack of commitment to funding of the NHS education has a knock-on effect in this area? That is the NHS education board, right, and the funding that should be really driving this agenda?
It's not just funding, it's actually a recognition of importance. So it's actually the Medical Schools Council that refuses to put this onto the curriculum, and therefore it's up to individual medical schools whether they choose to include it and how they choose to do that and contact it. So actually that's something that with the LGBT Foundation group that we've been trying to lobby to do. So although funding is important, it isn't just funding, it's actually acknowledgement that with the trans population of the UK, we estimate is around about 0.6%. We'll get onto monitoring later and why that's not an accurate figure. That's as many people as the population with Addison's disease. This is the number that we commonly quote, and none of us would dream about not being taught about that in medical schools. So it's a recognition of importance, and actually not letting any of these organisations, be it NHS, the Medical Schools Council, individual medical schools, say that this is not a high priority.
So the bottleneck we talked earlier on about 4-year waiting, is it because there's a lack of training for specialties who want to go to this, or is it that the demand is so much, so that's why the long waiting list? I mean, surely the number of consultants in the field have to be increased too.
Well, it's a combination of both. Yeah, it's a combination of both. The demand is very high, and also there's also not enough health professionals who are involved in gender, in providing gender health care, and it is a combination of both. And
the government often talks about bringing the competitive market forces into the NHS. One of the ways would be to increase the number of supply of consultants specialising in this field.
Well, absolutely. I mean, there are new pilot programs all over the UK in the moment, where GP led,
yes.
But there's still very few, and there's still not enough to meet the demands. Yep. And Salisa rightly pointed out, it's just also not just the funding; it's the recognition that trans health is important. And once that can be established, that can change the mindset of health professionals. Not only we also need to change the mindset about how we treat trans people as well. How healthcare professionals treat trans people. Yeah, and it is combination of both. And also lack of training, to GPs, lack of. I met a lot of GPs who actually wanted to ask me and says that, we are interested to know about hormone treatment, but we don't know how to, and we don't, and it's just one thing to say, to look at, to access e-learning. It's not the same as one-to-one teaching, because when I do one-to-one teaching, there's that I could see the response, and I can actually answers all these questions that they asked me, and as I said, that the mindset is thinking that it is healthcare for trans people is complex, but once after the teaching session, everybody says that actually it's not as complex as I thought it's going to be. So Yeah.
And just one final. I understand that there's a clinic called the Trans Plus,
Yeah.
which is a new pilot of the NHS Gender Dysphoria Clinic for adults that has been integrated with existing sexual health and HIV service on 56 Dean Street. I mean, you probably know more about this. But this is an example, right, of services becoming integrated, right? And it must be challenging that we've had sexual health clinics closed up and down London because of the lack of funding for these services, right? This is a government, right, which has really cut down these services, right? But here we see an example of innovative thinking, right? Do you think, are you concerned about the number of closure of these sexual health clinics up and down London, or which is an opportunity, right, for us to extend the services for the transgender patients also?
Yeah.
Do you want to comment on this? I do want to comment on this.
Michelle, please come in.
I feel
Michelle's
that
had her hand up for a
people
while.
online are being passed over and not being brought in enough. The Clinic here was the first sexual health and holistic well-being by trans people for trans people. We've been delivering services for the longest time of 10 years. We were the first in the UK and the whole of Europe. And what's important about having that trans people involved in this is not only can people informed sexual health and HIV services, but there's very much a gender care aspect to it as well. And however, there's not the only pilot that you mentioned. There's other pilots. The Indigo service in Manchester is very much GP-led. And that is the example that I really advocate for, because people can access it, local services for that. It's not so much centralised. It's that people can get it in various places throughout Manchester. You do need to be residing in Manchester. So there's a number. When we mention these pilots, we need to make sure that all the pilots in the different models that they're trying to see which one works best in which settings is really important. And yes, one of the reasons we, with my background in HIV for 34 years, is that's why we started in sexual health, because people were not able to access an informed service around sexual health and HIV. And there was no idea for over 30 years how many trans people were living with HIV in the UK. Now, for an high-income country, I work internationally, international AIDS conferences and various other conferences, and for over 30 years, there was no data in the UK on trans people. That shows by I'll just finish that sentence. By trans people living with HIV, imagine that for a high-income country not to be present with those details. I worked with Public Health England through Clinic Q. We created a way of making the HEARTS HIV and AIDS reporting system inclusive. And from 2017, we now have data which we're building on and need to continue improvements. And that's going to be part of our presentation at our conference. So yes, while they're important in sexual health services, they need to be much wider. And, eventually, places like Clinic Q and other centralised places should be less needed, because people can access all the services they need down the road at their local GP, who say, yes, we'll do this, just not turning people away. Anyway, I'm very passionate about this, that people understand this.
Yes, thank you, Michelle.
Thank you, and that passion comes across loud and clear, Michelle.
Okay. Well, it's a good job I'm not there.
Just before I pass on to the next section of questions, which are on cancer screening, which I'll be passing on to my colleague Emma Beth to lead on, I just wanted to pick up on one aspect that we haven't really covered, which is the kind of the other staff that people meet in a healthcare setting. So whether it's porters in hospitals or receptionists at a doctor's surgery. And I just wondered if anyone had anything that they want. I certainly know from trans friends of mine have described the kind of continual microaggressions of misgendering that comes from wider staff within healthcare settings. And I just wondered if anyone had anything in particular they wanted to say. Michelle, please go for it.
I do. Well, as you know, we work in an NHS setting, part of our service. Clinic Q is a an organisation, a CIC, Community Interest Company, but we have this partnership service that is supported by Lambeth, Southwark and Lewisham, the first to ever do that. We have, from the very front of house team, it's the forms that you give to people to show that they are included, to show that you see people, to show that their identity is recognised. Now, some people might not want to tick that, but there is an option. And also, when collecting that information, you have to ask for permission to record those details because of the Gender Recognition Act. And you can't ask for that, you can't ask for sight of it, you can't ask if people have got them. So we treat everybody the same. We have signed consent. And why we do that, because if they return to our services for the results or for another test, they'll probably see another person. And you've got to have permission because some of their details we disclose on the notes that are made in the NHS about their identity. So the next person that sees that has to see that they've had permission to be able to look at those details and be informed of this patient's needs. However, the rest of the NHS, there's no such thing happening. It's not happening in any other NHS services, except the one I mentioned about HIV and AIDS reporting and what we do at Clinic. Oh, some services that provide sexual health services for trans people do collect that data as well, do have those forms. But it's how you support the front of house team so that when they see the form, they can say, oh yes, rather than saying, oh, we don't have anything about non-binary, we can't record you, don't provide that service for you. And already that barrier starts there.
Yeah. Ryan.
Just on that note that you said, actually, which is really important, because we talk about primary healthcare, and primary meaning first. Your first point of call isn't the GP, is it? It's often that phone call. And it's like I said, that phone call of that patient where the receptionist didn't believe they were them because of the tone of their voice. And straight away, that patient's first experience of calling up the GP practice is one of feelings of not being listened to, not being heard, not being seen, and discrimination, essentially, because they made an assumption, and assumptions are bad. And that's why when we deliver training, sometimes when we deliver Pride in Practice training, they say, oh, we can give you the doctors at this time, or it's just these staff, and we do insist we will only deliver training if there's a selection of staff. We make sure we're delivering training to receptionists, to supportive staff, to administration staff, to the GPs, so we have that wide selection and at that level, because it is important for everyone at every level, because any interaction could be a negative one that stops someone accessing that service, which healthcare is all about people feeling confident to access that service. And that's why it's so important for every member of staff to have that awareness and training.
That's really important. Thank you, Ryan, for that. And also, when people do register, so say a trans man registers at the GP and they might need cervical screening at some point, they are not then included in the national programme because they're men and men don't have cervix. Well, actually, I know a lot of men that do. And
Michelle, can I just interrupt just a second? We're about to move on to absolutely that point that you're making, but I'm going to let Emma lead off with I'm going to let Andrew come in with a quick further question, and then Emma's going to lead on the questions that will relate to the points you were beginning to make, Michelle.
I'm not sure who wants to come in there. I'll start with Mr. Chase. Did you know that the Mayor's Health Inequality Strategy is 184 pages long and doesn't once mention transgender people?
I didn't know that specific fact, but it doesn't surprise me.
Do you think it should?
Sorry, repeat the name of the document again?
It's the Mayor's Health Inequalities Strategy. It's one of the statutory documents that the Mayor has to produce as Mayor of London. And in its 184 pages, it doesn't mention transgender people once.
It probably ought to mention us, yeah.
Thank you. Anybody else got any views of whether or not the Mayor should be mentioning transgender people in his health inequality strategy?
Yes, of course they should.
Yeah, and it's 100% that essentially when we contact a practice, it's from the ground up. So we can be quite easily dismissed as an external service that's trying to get in touch, deliver the service. What is happening from above? Pushing down, putting pressure on practices. The Mayor is a great example of that. So where is the statement from the Mayor in things like the health equality strategy, in a statement to say, GP practices, come on, in Lambeth and Lewisham, you've got a free service, it's funded until March, why aren't you doing it? Essentially, after March, there could be no pride in practice in London because we're only funded until then. So 100%, yes, it should be in that.
Good. I see everybody else nodding, but...
Unfortunately, often trans people are, not are often forgotten or ignored, or in health inequalities. Like even NHS, when they produced a report on health inequalities during the COVID, there was no mention for all about LGBT or trans people, and yeah, it's unfortunate. I don't know why, So, and then this is.
Did why?
Sorry. Yes. So it is crucial that that trans people and are included in health inequalities. Yeah. I mean, we are supposed to provide healthcare access to healthcare to everybody, irrespectively of their race, their gender, sexuality, or color, kind of thing, or religion. So somehow trans people have always been, health equalities have often been neglected. Yeah.
Thank you, Chair.
Thank you. Just to be clear, I think the Mayor is a very vocal trans ally, but I think it's on all of us that it slipped through when because we all looked at that health inequality strategy, and that's on all of us that we didn't pick that issue up. But the Mayor has been in this chamber a vocal trans ally when, and you, Assembly Member Boff, helped when there was some transphobic language from a former member.
Words are easy.
Exactly, it's easy to say you're an ally, but actions speak louder than words.
And Andrew, I'm mortified that certainly when I looked at that health inequality strategy, I didn't spot that, and nor did the Health Committee in the former term when that strategy was being looked at. So it kind of shows us all how we must do better. Emma, can I move on to you?
Yes, of course, and hopefully today is a good start for that, Caroline, on that point. Yes, so thanks everyone for your contributions so far. Moving on to cancer screening, and I just wanted to pick up, Ryan, quickly on that GP call, and I keep having flashbacks to a particularly painful conversation I had not long ago, trying to tell the GP practice they were trying to get in contact with my son's other mum, not me, and how long that back and forth went through. So moving on to cancer screening, Alison, I wanted to throw some questions to you, if that's all right. So firstly, wondered if you can explain why some trans and gender diverse people may be more at risk of certain cancers?
Yeah, I guess there's cancers and changes to risk fall into a number of different groups. So they're the ones that I think come most obviously, certainly to clinicians' minds. So that's where someone might have take hormones or have a surgery in the course of their gender affirming care. That means that their risk is altered compared to if they had not done that. So I'm thinking, for example, trans women who have estrogens increase their risk of breast cancer relative to cisgender men who are not taking those hormones, but that doesn't put them at a hugely increased risk compared to cisgender women. They still have a lower risk than cisgender women. So there are things that are related to gender affirming care, and they're not blanket. It will depend on what hormones or surgeries you have and how that intersects with other aspects, so perhaps your genetic predisposition to cancer. Then there are situations where the trans community might be at higher risk of certain cancers because they have other risk factors that are higher. So some subpopulations of the community might have higher rates of smoking, use of alcohol, higher rates of HIV, but it doesn't apply to everyone. But those kind of facts around risk factors will affect someone's risk. it's a good point to come in here, and it links to the last point that actually we don't have incidence data that is good quality. We do not collect trans status or gender identity in the cancer registries. So actually, whilst we make inferences about this risk from other populations, we don't have the proof that those incidence rates are higher or lower in this country. Studies have been done in other countries, so the data, for example, that talks about breast cancer is drawn from the Netherlands, and they're doing some fantastic work, but their gender affirming care is different to ours. There are other studies, and I work with a group from the NIH in the US, so they have looked at cancer registry data there, and they have picked up that the trans population there are at higher rates of lung cancer, they have worse outcomes from bladder cancer, from non-Hodgkin's lymphoma. The problem with that data is that it comes with all the biases of a different healthcare system, and it's not disaggregated for the person's sex assigned at birth, any gender affirming care they will have accessed. So where we do have cancer incidence data, we then don't know why. And then the final thing relates to screening, and I know you're going to ask about screening. So we know from studies in lots of countries, including here, that there is lower uptake of screening, lower chance of being up to date. The data in this country isn't fantastic, but again, in the US, we've collected that data. But again, because of the lack of incidence data, we can't make the link to saying, well, that definitely results in higher rates of cancer or in worse outcomes, even though all of us that work in the setting know it will happen. So we again did a pilot looking at cervical screening. Actually, it was with 56 Dean Street, and we know that we picked up in that tailored pilot someone who had changes, but that's like a one-off story because we're not collecting this data as a whole. We're actually unable to pinpoint those exact healthcare inequalities and what's causing them, and cancer is just an example of that.
Just before we go on to screening more specifically, do you think there's anything more we could be doing on monitoring, anything that the Mayor could be requesting that would be helpful?
Well, time and time again, and LGBT Foundation, and I know the others in this panel are great advocates of this around the introduction of monitoring. Obviously, monitoring is not just saying you must collect this data, but also building trust from the community so that people feel that they are able to disclose that information, and healthcare campaigns that are embedded within the community and the community of all ages and backgrounds that allows them to understand why disclosing is important, what the aspects of that are relevant to their healthcare might be, so that they can to understand why that information is important directly to them and why having the registry information is important for the community as a whole. So that I think would be hugely important. I can hear Michelle coming in online. Is there anything you wanted to add, Michelle?
Yeah, I think you've given some great examples. Thank you, Alison, for that. It's because we talk about without data you're invisible, really, and that really is the fact. With the HIV and AIDS reporting system, it's not just that we collect numbers of people living with HIV. We're able to compare the issues of living with HIV for trans and non-binary people with cis people living with HIV. And we've got really clear similarities and inequalities from that. And it's really important that we have that as an example of really collecting inclusive data that not only look at the rates of HIV, but look at the other issues as well, the social issues, the health issues, the adherence to HIV medications, and the many, many issues involved. So we have that, and I'm happy to send those details to you. And we're looking at how to improve that data collection with Public Health England that will bring out even more details, and how the differences in the UK of people living with HIV compared to the rest of the world. And we can look at those. And I think that's got to happen in all health services.
Thank you, Michelle. Moving into...
I've got a hand up from Rico.
Sorry, Rico.
That's okay, don't worry.
Yeah.
We're sort of knitting everything together, so I appreciate it. Yeah, so just to quickly on that, it's important to see people as individuals as opposed to not their assigned gender. I don't think that the NHS healthcare systems actually have that flexibility. It took me about 4 or 5 attempts to actually change my name on the systems because the systems aren't actually aligned. There's misalignment there. I would say that just to sort of chime in when it comes to people feeling comfortable going to access healthcare, as a POC person, I know that historically we don't actually feel comfortable going to healthcare providers, and that's for sort of legacy reasons to do like racism, etc. So statistically, my demographic do end up having later stage of cancer, and we catch it slightly late. So the same thing can be transferred onto the trans and non-binary community. We don't actually access healthcare at the earlier stages because we're avoiding it. It's the avoidance there, and that will hopefully be fixed by the educational programs that we were discussing earlier. Depression and anxiety, because of the issues we were discussing earlier, we have a high propensity to depression and anxiety. That means that there's a large amount of substance abuse. And as all of you know, if you look at the food prices in any in any local store, it is quite expensive in order to buy vegetables, sort of keep yourself healthy. That costs money. So if you have a lower income, you're not going to be able to keep yourself in a good shape. Gym membership, I mean, all of those are points of privilege. So all of those sort of factor into the sort of cancer discussions that we had earlier. But yeah, that's what I wanted to say.
And just to come in on the monitoring before you ask the next question, the knock-on effect for that is also that because you don't know the problem, you can't get any research funded to sort it out. So time and time again, I come up with a great idea and then say, well, no one's ever going to fund it because you haven't got any pilot data. Nobody knows what your denominator number is, and you don't know where people are. The same, we're trying to bring a business case to NHS England for a specialist service, but I cannot tell them what the demand for that service would be because I can't put a number on it because it's not monitored. And so it compounds the problem.
Camilla?
Just a quick addition to what Alison just said. Yes, there's this lack of data. The data, not say lack of data, the data is out there. The data is in general practice. Everything is general practice because all of us are registered with our GPs. So if you've got cancer, or if it's documented in your medical notes in your GP practice. Problem is that there's no trans status monitoring. So so perhaps maybe I would like to make the Mayor of London or London Assembly to actually I don't know, pressure or to tell the NHS that that you need trans status monitoring. That's the only way that actually to. Well, what is the main barriers actually to improve healthcare for trans people?
Yeah, that's right. Can I just say, I'm doing a training at King's College, the King's Fund tomorrow, and we're working with new registrars, HIV clinicians and other clinicians, and it's looking at all these issues of data collection, but not only data collection, the inclusiveness and why that's important for people going forward, and how by working with trans people in your practice, how you are creating a good practice, good care for people. And people, it's packed out, and it's at the King's Fund. I don't think you can just come along, you've got to be invited. So we often do this within a certain sector, especially the sexual health and HIV sector. But this kind of thing needs to be happening throughout all health services. And as I said, I'm working with King's older service for people who are residential in King's because they've had trans people who are really terrified of being in that kind of service setting. So anyway.
I think message received, and Caroline's been furiously making notes on that. So just moving on, Alison, stick with you, and obviously shout me if somebody's got their hand up on the virtual screens. So Alison, can you outline the current guidance on cancer screening for trans and gender diverse people?
So I'll just talk about the 3 national screening programs for cancer. So we have NHS bowel screening, which is I'll start with that one because it's not a gender-specific screening. I won't go into the details of eligibility and the way that that's done, but if a patient does need follow-up testing, they will need a flexible sigmoidoscopy, and as part of that, that does involve dressing from the waist down. And so what I want to mention before anything, that actually people think that bowel screening is exempt from being an issue for the trans population, but it's not, and there are barriers higher up there. But that's less of a kind of, the immediate delivery of that is less affected. Then there is breast screening. Now, breast screening is recommended for those over the age of 50 and in some areas now over the age of 45. So it's recommended for those who are for cisgender women in that population. For trans women, because there is breast development on estrogen, it is recommended for trans women who have taken estrogen to undergo mammography screening in that way. And there is the kind of local guidelines for this differ, but there's a recommendation to delay starting that between 2 and 5 years because of exposure of the developing breast on estrogen to X-rays. But that's recommended for trans women in the same way as is for cisgender women. Trans women will only be called automatically if they are registered as female with their GP, and for a non-binary person, again, it would depend on how they're registered. For trans men, there is a small amount of breast tissue left remaining for most trans men that have a male chest reconstruction, but because of the amount of breast tissue that's removed, that does lower your risk. So in most cases, trans men are recommended to self-check if they've had that surgery. If they've not had top surgery, then they should still have mammography, which can be quite a dysphoric procedure, and they again will not be automatically called if they are registered as male with their GP practice. With regard to cervical screening, it's recommended over the age of 25 every 3 years, and then that screening interval lengthens later in life. It's recommended for anybody with a cervix. Again, we currently have the issues around a lack of automatic calling if you are registered as male with your GP. Large numbers of trans men are choosing to not have a hysterectomy, and non-binary people even more so, because they're choosing to think about whether they want to become pregnant in the future. They don't necessarily want to have that surgery. They may want to retain ovaries. There are lots and lots of reasons, and there's a lack of awareness often that there will be a large proportion of trans and non-binary people with a cervix. There's systemic barriers, as I've mentioned, around not being called, as well as dysphoria related to the procedure, dysphoria related to screening correspondence. A lot of that is beginning to be changed now. Gender neutral information produced by Joe's Trust, better information going out from Public Health England, and in the new year we're being told that the new recall system will allow for those registered as male with their GP to be able to be called. Now, that was due for rollout last month, but that new system has been delayed. It still relies on GPs picking up that they have trans men who need this service within their GP practice and enrolling them onto the system, which needs a person to feel comfortable to disclose, and a kind of conversation around that. There has been a lack of awareness from Public Health England, who I've had conversations with through my work with LTT Cancer. I know Camilla has done the same, around actually the amount of support that both GPs and the community will need in order for that system change to make any actual difference. You can't just say, oh, actually we're going to make this recall possible now. You need to skill GPs to be able to ask the question, reception staff to be able to ask the monitoring questions, the community to be able to acknowledge that they need the test, to feel visible in that space, training for better training for GPs to be able to deliver that cervical screening, as well as the sexual health services, who the burden has been on for a long time, Clinic U, 56 Dean Street, Clinic T in Brighton. And it's still, again, from a piece of work that we did and research of trans men and non-binary people that we surveyed, 64% felt that they still prefer their cervical screening test to be in a trans-specific service. So I totally agree with Michelle that we need to ensure that all of those services can be delivered in all GPs, but it can't happen overnight. We actually need this sort of graded response where we improve the availability of trans-specific services and upskill everyone together while that trust is built. None of this is going to happen overnight. That was a very long answer to your question.
But a very good answer, so thank you, Alison. So I think I'll ask you this last one on the screening, and perhaps other people might want to come in at this point. But just, you kind of covered this a little bit, but do you believe the current system is working well to adequately screen and provide sufficient information, access and support?
No. I don't think everyone will agree with me. I'll let the others in the room contribute, because I've spoken a lot, and then I'll come in if there's anything I felt I haven't covered.
I think Rico looks like he's got something to say.
Well, can I just say, thank you, Alison, for all that, what you said as well. And the question that was just asked, well, no, it's not adequate. And also, if people do turn up to a GP and they say where are the people sent? You know, there's fine if they can access, you know, in a London and Brighton, there, and we do see a lot of people for cervical screening, a lot of people. And but what about outside of London? What about outside of centres? What about, you know, in small villages, small towns? People are not getting those kind of services. They're having to travel to London for 2 hours to get something like that. You know, we really have to make a change here. And when people do, where does their GP send them if they don't do it? Do they send it off to a cervical screening clinic, which is all cis female orientated, and understandably get that? But how does that change?
Ryan?
Yeah, with the current systems, hear that word a lot. It's the systems. So from someone that sort of works with GPs on that level, as soon as I get into this section on the assessment that we do, I ask the question, how are you making sure that all of your patients with cervixes are getting screened? And pretty much every time it's met with, don't know. Do you have monitoring in place? Do you keep a record of your every patient with a cervix? Often no. So therefore we then go through, how do you then adapt your new patient registration form? How do you ask these questions? How do you monitor? And like was previously mentioned, not just monitoring, because monitoring in itself is useless. You need to monitor and use the information, store the information. And unfortunately at the minute it's tough because the systems are against them. So every practice I work with has to do a workaround. They have to manually do it. I've had a GP manager that has texted all of their patients, because it's fair enough changing your new patient registration form now, but what about your existing patients? And that's a lot of work, that's a lot of time, and we keep saying about time. Time is of the essence in a GP practice. So could it be made easier for GP practices to be able to monitor and make sure that everyone who needs screening is getting invited?
Ryan, just to stick with you then, do you think there's anything the Mayor could do specifically to work with healthcare delivery partners to advocate and support those changes?
I think first of all, making it aware that there's an issue, because a lot of practice, when I bring up trans men or people with cervixes being missed off of screening, it's often met with, and actually a lot of the feedback I get, because I asked for feedback after the training, is that was really insightful about the screening because I didn't know that. And when we're being told by GP practices, I didn't know that, that's a worry. So I can't magically click my fingers and make every GP practice in London be aware of that, but the Mayor certainly has a better chance than I do to be able to go, this is an issue, you need to make sure screening, because there has been a push in media of recent years that screening is so important, cervical screening, but has it been mentioned that people are being missed because of their gender? Not in any mainstream media or real valuable place where it needs to happen.
Do you think perhaps the Mayor could use some of his advertising budget to...
100%, yes please.
Yeah.
Use it all.
There is an issue, sorry to interrupt, there is the issue that, to be fair for some GPs who are fantastic as well, that they might have one trans patient that turns up now and again, and their familiarity of working with trans people kind of takes a back seat. So there needs to be a way that GPs can keep aware of that, whether they see one person a year or one person every few years. It's really important that they are kept aware, as we're all saying here really. But I do understand that if people are not familiar with working with the issues we've all been discussing here, that it kind of takes less of a priority in their day-to-day work. That's not an excuse, it's just how it happens.
Visibility is also just like hugely important, and like environment. And I think you just touched on very gendered spaces and screening there. Like that's hugely important and under recognised. Seeing yourself in screening campaigns. So LTT Cancer is actually working with some of the London Cancer Alliances to have more inclusive screening information for actually LGBTQ people more broadly, but actually an awareness even in all of those places delivering screening, that what a difference that environment can make. Perhaps if you've got a trans guy coming for chest screening, that they might want an appointment that's at the end of the day, so it's like a less gendered waiting room, or having a discussion about that, how you can adapt that process to make it most comfortable for them. Just a bit more kind of training and visibility and stuff around that is just so important. And people often say, oh well, they might just feel a bit uncomfortable, and it's like dysphoria is not feeling a bit uncomfortable, and actually there's so much to be done around educating people about that in itself.
Can I just say, we're about to start a new campaign on cervical screening in South London, and also you might not have noticed, but Alison just used a very inclusive term. Chest screening for trans men is really important, rather than saying breast screening, which is often the usual term, because trans men are men and they usually talk about their chest.
Sure. I think Rico, you wanted to come in.
Yeah, just chatting on that. LTT charity was actually started during the pandemic, and a friend of mine runs it, doing absolutely brilliant work. One of the campaigns that they're working on was with a cancer charity, a well-known cancer charity. And part of that campaign, they realised that you don't necessarily need to talk about it's like breast tissue, and anonymously, if I don't necessarily need to say breast specifically, but also straight men, cishet men, actually have breast tissue. So straight men can also get breast cancer. So it's important to create resources that aren't gendered, because breast cancer isn't gendered as a disease. And when they were creating the resources themselves, they just used fruit. Because what are you trying to convey? You're trying to relay information about how to prevent you from getting cancer. The tissue itself isn't really applicable. The gender of the person isn't applicable. So they just use fruit, and then the fruit guys isn't going to trigger someone with gender dysphoria, and that in itself is just useful. So it's finding ways of relaying information without triggering the person that you're trying to protect. Yeah.
Thanks.
Yeah, I mean, just a quick addition. What Alison just saying, that screening is just not just about screening. I mean, screening can be used for inclusivity in healthcare for trans people. When a trans person goes to see the practice nurse, for example, most of the time they see the practice nurse for their cancer screenings. So there are other things that they discuss with the practice nurse. Just like in my experience, when I contacted all the trans people in the cervix to come in for cervical screening, they would actually reveal a lot of things to the practice nurse. Say that they have this how the psychological health is impacted, so how, that they are, they have housing issues, they have other, they have, the other healthcare that actually that they will discuss with practice nurse. So it's a very valuable opportunity for actually trans people to to discuss the healthcare with the practice nurses when they come for the screening. So it's just not about screening. It's a lot more about about healthcare. So, but cancer screening is a very useful tool, to, in my opinion, to actually to get to more trans people to be more involved in the healthcare.
I think we'll pass back to Caroline then at that point, and if you wanted to.
Thank you, Emma. And we'll now move on to Andrew, who's going to lead us on an issue that has been touched on throughout the morning, which is the issue of patient records. But Andrew's got some very specific questions on patient records, and we suspect that there may be some recommendations that we may be able to make around patient records, and certainly from what we've heard so far, it sounds like it is a really important issue. But Andrew, over to you.
Just for reference, sorry to talk amongst ourselves for a while, but I'm not going to do question 15 because I think it's more than been answered. But question 16, and that question is, how can the NHS improve recording for biological sex and gender identity? Nice and concise. What should the NHS be doing? Miss
Michelle, you're muted.
You're on mute.
Miss Ross,
Mute. All right, thank you. And I just kind of reacted to the term biological then. It just kind of struck me. But I will mention the Hearts and Clinic Q. We use a two-stage data collection, and that people can respond to, and I can always share that with you. I can share you the stuff from Public Health England that show how to collect that data as well, and how the results of collecting that data and all health issues. And it's a very simple way of doing it, the two-stage data collection, and it really shows that results. I mean, other people might have other ways of doing that, but I think the simplest way you need to do it is to make sure that it's accessible, easy for people to fill in, and visible, but not only for the people that you're giving this, say, a paperwork to, but also the reception staff, so they keep seeing that these are inclusive. So it does collect it. Also, Dr. Michael Brady, as I said, the NHS advisor to LGBT health, is working on this kind of issues throughout the NHS on collecting data and how to do that.
anybody else want to come in on that?
Just from like a surgery perspective in terms of monitoring and new patient registration forms, that's particularly my area that I focus in when training and looking at how many patients do you have that are trans? How are you, like Michelle just said, are you using the right language, first of all? So first of all, you need to know that the data needs to be collected. Then you need to collect it in a respectful way, using the correct language, because if a trans person sees their question being asked, but it does say certain terms or certain words, they're not going to feel included. They're actually probably going to feel more triggered than if it wasn't there at all. So knowing it needs to be asked, knowing it needs to be asked correctly, and then knowing the data needs to be used. We actually have a guide. It's available to download on our website, called "If We're Not Counted, We Don't Count." And I just think that statement in itself says a lot. If we're not counted, we don't count. And that was created with Dr. Michael Brady, like Michelle has mentioned. And there's a full guide in there of what language to use, why data is important, and how you can use patient data, specifically when it comes to monitoring. And from a survey we did, 62% of trans people were more likely to feel their GP met their health needs when they shared their trans status with their GP practice. So just that initial sharing your status, having it on a form, being monitored, can already break down lots of barriers.
Be helpful for the mayor to take the lead on pushing for these changes to the recording of data?
Yes, definitely, because like Michelle said, Dr. Microaggressions and lots of people, the systems are outdated. They're so outdated and they get in the way more than they help with NHS staff. So to make those changes, more publicity, the better, and pressure put on those changes to happen.
Sorry, Dr. Berner.
And just to say that those monitoring recommendations that were done through Michael Brady's team and LGBT Foundation and all the other organisations went out to consultation to lots of trans groups, and it's really important to then stick with what people said and what people thought. So otherwise you end up with the example of what happened in the census, where the question was changed at the last minute this year, and as a result all of your census data on gender identity and trans status is going to be incorrect because the question was boycotted, because it started referring to legally recognised and all of these things like Michelle mentioned, that suddenly talking about biological sex in a way that can be incredibly triggering to people. So I think it's an example of if you do something that's inclusive, then go with what you said you're going to go with the conclusion, because the question was changed at the last minute and everything ended up really, we're not going to be able to use that data, which is quite tragic really.
With regard to the rest of my questions, I see them as being answered. Unless, Chair, you wanted to... We've had very thorough discussions about data.
I agree. Is there anything anyone wants to add about data? Anything else about what data? Yes, how important data is and what data can do. So, Camilla, we'll start with you, and then we'll go to Ryan.
I just want to have just a quick addition to. I mean, when we're talking about collecting data in general practice, I would like to have actually a lot of GPs to be involved in as well, because not just we understand that that trans people wants to identify in a certain way, but you also have to understand that how we collect data in general practice, because we collect data, we're doing search. And unfortunately, by using this two-tier system, by doing the search, it does not actually identify who exactly is trans feminine or trans masculine. So it just also makes it very difficult for us to actually to provide person-centered care. Yeah, so we need to have a discussion between the two sections kind of thing, and not just, I mean, I'm a GP myself, and I'm a trans person myself, so I understand from both sides kind of thing. And so I think we need to have, discussion from both parties, yeah, to actually how to actually to move this forward. Yeah, I'm also actually quite frustrated because there is no at the moment in general practice there is no way actually to identify who exactly is trans a person.
Yeah, and that was a bit what I said earlier about practices are expected to do their own workaround and make their own Excel spreadsheet, and obviously that's time and difficult. And also with I spoke to a GP practice manager the other day, and they said the only way they can make it clear to a doctor, because obviously you get 10 minutes in a consultation, is to add a warning. So a warning will actually pop up, and just that word, a warning, to say that someone is trans and uses certain pronouns, and that was the only way they could think of making it clear to a doctor, a GP, before the patient comes in, that they use a certain pronoun, is to pop up a warning message onto the screen. Obviously, I'm going back to systems, not ideal. They're having to do their own workaround, and yeah, things need to change. And just to reiterate that a trans person can change their name and gender marker at their GP practice just by requesting it. They don't need to have a gender recognition certificate or undergone any surgery or hormone therapy, anything. They just need to request it. Now, the process to change that, I'm not going to go into now, but we have a guide on that. There's lots of information out there. But just to reiterate, a lot of GPs think there's a barrier there just to change their name and gender marker. But there isn't. They just need to request it.
Thank you. Anka, I know you want to come in, but I just wanted to apologise for the wording of the question which used biological sex. And Dan has very helpfully just told me that it came from the 2019 RCGP recommendations. So I'm sorry, we've tried with this briefing to be inclusive, and that shows how easy it is to fall over, and I'm really sorry about that. Yeah, that's anyway, an apology, and I didn't pick that up as chair, and I'm sorry because
pick it up
that left
when I
you with
asked the
that question, and I'm sorry about that.
And shamefully, I think the RCGP is the one who's actually responsible.
Just reiterate how much of a worry it is. If it is on that formal documentation, then yeah.
Well, yes, it shows. It kind of indicates the scale of the issue that everyone is dealing with. But I did just want to make that clear. Onka, you had a question you wanted to come in with.
I mean, in terms of data collection, this must imply that there is a problem with read coding also, right? That we don't have the read codes right to control the right information. So one of the things which could be done is the read code could be created for GP computer systems, which give us the information to record appropriately.
It's a bit complex because the read codes in general practice are actually international read codes.
Yes, of course.
Yeah.
Yes.
And at the moment, there are no read codes, to identify that you are, like trans feminine or trans woman or trans masculine or trans man. Yeah.
But they could be created, couldn't they?
They could, but it's like I've been trying to change this for the past 3 years. So
this is the opportunity for us to raise that concern.
So it's NHS X or NHS Digital, and every time when I speak to them, something like that, they say that we are actually talking to SNOMED. SNOMED is an international read code, so there are some changes, that they don't use transsexualism anymore, and then they used to have a really offensive read codes, sexual encounter with a transgender, and saying what's got to do with it with clinical care, but that has really gone. So there are some improvements, but there's still, at the moment, the read codes that are available on the GP practice system is transgender, intersex, and non-binary. So these are only like the 3 codes that are available. Because when we do, when we try to do, like for example, call and recall for cervical screening, we do a search, and we just, we do a search. We look at, like for example, women under, between 25 to 65. So we do a search kind of thing like that. So, but we at the moment we're not able to do that for trans people because there's no read codes. So that's how difficult it is. And the trans status monitoring kind of thing. I mean, there should also be a lot of awareness among trans people that we are using the read codes only for their own benefits. It's just not that we are actually to discriminate or to misuse the read codes. No, but I think the read codes are actually meant to improve healthcare for trans people. And there's a lot of data out there, about prevalence of diseases, that is just, not, able to do that, because there are no read codes. Yeah, we're talking about, prevalence of diabetes, prevalence of, thromboembolic diseases, prevalence of, heart problems, loads and loads of diseases, kind of thing. We just could not measure that at the moment, but the data is out there.
Of course. And to you, Ryan, I mean, you talked about the discussion between the GP receptionist and transgender patient and health. I mean, this discussion, let's not forget, is taking place in a banker's window, right? Okay, reception desk, right? Rather than an individual room, right? Which actually brings to the problem of the infrastructure of primary care premises, right? That we don't have separate rooms, right, where these sensitive discussions can take place, right? That the receptionist has certain barriers and the patient has barriers, right? And there are 2-3 patients standing behind you, right, dealing with it. And sensitivity of this discussions, right? What I'm alluding to is that the infrastructure in primary care is lacking at the moment, of lack of investment in premises, right, to create the environment for those sensitive discussions to take place, which is sensitive to the receptionist and sensitive to the patient in front. Would you agree with me, or maybe I should ask you, really asking a question rather?
Oh yeah, that's a lovely statement. Completely agree.
Great, thanks.
Okay, I just want to thank everyone for your time this morning. I've highlighted things. I've written copious notes, and I've highlighted things like Ryan said at the very beginning. Just a poster on the wall can make someone who's LGBT feel that they're visible and that they're heard. It was Ryan again said that nurse training takes 3.5 years, and LGBT issues not mentioned once during that training. Heard very strongly, particularly from Michelle, about the importance of trans-led co-delivery. And things like putting a confidentiality policy on your website, having stuff about LGBT issues on your website makes a practice feel more inclusive. Ryan wants all the practices knocking at the door for training, and the point that Michelle made about trans people feeling exhausted and feeling that we're still just scratching at the surface on dealing with all these issues. We heard about the importance again of more trans-led services highlighted, finding ways to show how people are included, collecting the data and building the trust so that people can disclose, and then the importance of language, particularly when collecting that data. Now, I just want to give all of you...
Chair, you've left out quite significantly the fact that the mayor has to take a role in this as well, because this is what we're about.
Yes,
this is what this
is about. And the government.
Yeah,
this is what this committee is about. We're holding the mayor to account, and the mayor hasn't done anything on trans issues apart from say some nice words.
Yep, no, and
we've got to hold them to account for that.
You're absolutely right. I was listening to what we had heard from our guests, and absolutely there are some really important recommendations that I think that this committee can make, and to push the mayor, particularly with his advocacy role. And a lot of what we've been hearing about is just more visibility, more information. Sorry, Krupesh, you wanted to...
I just want to correct the record, because I think it is actually quite unfair to say the mayor's done nothing on trans issues. I accept that maybe there's a point around healthcare, but if you look at other sections that the mayor does oversee around policing, crime, also around culture and organisations and projects that have been directly funded by the mayor, I think it's wholly incorrect to say he's done nothing.
This committee is about health.
You said nothing. He's
done nothing.
Let's not have a political squabble. Let us move on. I am sure we will have some strong recommendations both to the government and to the mayor. And I did say that the mayor has been a very strong trans ally, and particularly in this chamber. I think I wanted to give the final word to our guests, and to give everyone a chance to either emphasise something that has come up this morning, or if there's anything that you think you really hope you will see in our outputs. And I'm going to start online, and I was going to go to Rico. So I'll come to each of you with just one idea of one thing that you'd love to see in our output.
Sorry, before I sort of talk about that, I think when it comes to trans-specific health, I'm not sure we've kind of discussed that sufficiently. I mean, cancer screenings is probably towards the end of the process. I don't think we've actually addressed the main issue that we're facing as a trans and non-binary community, and it is trans-specific healthcare. I don't think that that's necessarily been covered sufficiently, personally. So, for example, the 5-year waiting list, I don't think we've discussed that extensively, or the fact that it's gender care and gender duty. I use them personally, so I have no problem with them. But accessing those healthcare providers is a point of privilege. We have discussed how the mayor could potentially reduce those waiting lists, having increased funding or training for medical practitioners. Where there is a slight conflict of interest with the same people that are actually providing the private healthcare or providing the NHS. I don't know about you, but if I could get paid a lot more for doing something, or do it for a reduced cost, I know where I'd go. I mean, those sort of things need to be controlled, and the NHS waiting list is ridiculous and it's going up. When it comes to phalloplasty, elective care was provided in April for all surgery apart from phalloplasty. Why is that? There's a lot that needs to be done, and I think focusing on cancer and non-transspecific care hasn't really addressed the elephant in the room. So if we do have time in the next half an hour, before we close out closing thoughts, it may be good to sort of discuss that first. I don't know what the rest of the room says. I can't really see the rest of you. I can only see Michelle. But yeah, I don't know if anyone else wants to talk about that.
The meeting was scoped specifically to be because obviously accessing gender identity services is clearly a huge issue. It's something that is very clearly, with waiting lists sort of 4 or 5 years long. It's an absolutely massive issue. The Mayor of London doesn't actually have any sort of he has a role in health inequalities, doesn't have an issue in delivering NHS services. The NHS is kind of, the governance of that is sort of national. So what we tried to do with this meeting was to focus on issues where we might be able to say something that could actually make a difference and where the Mayor could make a difference, which is why we focused on that experience of walking into a health setting and the discrimination that trans and gender diverse people experience, why we focused in on the screening and also on the keeping of patient records, because we felt that there were things that we can recommend to the Mayor in our role as scrutiny of the Mayor, and that's why there is that gap. And I'm really sorry if that wasn't sort of made clear during the.
I understand that point, but I mean, if that is the underlying issue, discussing those waiting times, it kind of like leads nicely when it comes to funding. So say, for example, clinic Q right there, 56T. I went into a meeting 56T and they sorted me out an hour. It's like, as opposed to 5 years or like an hour meeting. A Spectra as well, Chelsea and Westminster Hospital, there actually are pilots which are in the remit of the Mayor, which probably would it would be a godsend if they got increased funding. So I support that. But that was my 2 pence.
Nico, would you be able to write to Dan, to the scrutiny team who've been in touch with you about attending the meeting with the details of that, because that would be really helpful.
That's happy to help.
Can I say?
Michelle, yes.
Just say I want to, and know absolutely what Rico said about that real crisis, and we see it every day in our counselling services. We see how we're overwhelmed by the need from within London and further afield of access to mental health support through Clinic Q. And, so we're also at our service at King's, we do a lot more than what I've maybe spoken about here for gender care. So if somebody can't get a blood test at their GP, we can sort it out within an hour. They make an appointment with us, they come down on that day, it's done. When it's first cervical screening, it's done. All those issues, a lot of health issues, are sorted through Clinic Q with King's College Hospital, who have really embraced what we do. There's one way that the Mayor might be able to help a non-NHS services. Clinic Q is a CIC, and so are other people. So funding, making funding accessible so that we can further and develop and grow core funding as well to provide the services that can make a very huge difference. And South London has been a real neglected area for trans health and issues. And by Clinic Q moving to South London, to King's College Hospital in 2019, we made a huge difference for local people. There need not be one gender care service in London. There could be more. Each borough can help with that, and maybe the Mayor can help with that as well.
Thank you very much. Camilla.
Sorry, I have to leave soon because I've got a teaching at Finchley.
We're in the process of winding up. So.
Yeah, so I just be quick. Yeah, I mean, I truly believe that our mayor is a trans ally, and he presented an award and he presented an award at Pink News last year, and I received an award from him last year. So and I followed his, what he's done. Yeah, but of course there's still a lot of room for improvement. Can think that need to be done, especially in healthcare. And from my personal perspective, kind of think if the mayor, the mayor of London can actually, raise a lot of awareness to campaigns for inclusivity in healthcare. I mean, this would be very, very valuable. And also to provide funding for community services, for example, like Spectra London, LST Cancer, Transsexual, Clinic Q. We all want some sustainable funding, it's something that we really do need at the moment. So
Sorry, I just want to chime in quickly. I know that everyone wants to sort of run off and go to lunch, but just quickly. So there is an app called Lavender Healthcare, and Lavender Healthcare is run by a non-binary person. And what they're trying to do is they're trying to remove the reliance of having to go physically enter into a clinic and get the diagnosis. They're centralizing it, like things like ordering PrEP for HIV. You can order that to your house. The reliance doesn't necessarily need to be so heavily on the NHS. So they're making it less resource heavy. So having a centralized app also addresses some of the issues. I can't remember the lady in the room, the trustee at Lavender, not Lavender, trustee at the cancer charity was saying, if you have reservations, legal reservations about giving out hormones, etc., having it on a centralized app means that the ramifications is on the application and the people that are providing it. So having things centralized just removes all that risk, and it removes some of the resource issues. So they're currently, it's a free application, so they're currently going to each different body in London trying to get sign off. So that's a potential option there. And I'm going to shut up now.
Thank you. That's appreciated. So I'm going to come to Alison and Ryan. Who wants to go first? Okay. Ryan.
So my request to the Mayor is please reach out to Dr. Michael Brady, our NHS LGBT health advisor, and I would love to see him sit down with Dr. Michael Brady, discuss LGBT health inequalities and make an official statement after that meeting. That's my request.
That's a simple request. I'm sure we can make sure that gets made.
Sorry, I'm not speaking on behalf of Dr. Michael Brady. I'm sure Dr. Michael Brady would be thrilled to sit down with the Mayor, but to reach out and have that meeting, I think would be fantastic.
Brilliant, thank you. And Alison?
I think to provide support, both financial and non-financial, to trans and non-binary people who want to be involved in healthcare and work in trans healthcare, whether it be in a kind of formalised, recognised health profession like nursing, psychology, medicine. It takes a lot of different healthcare professionals to deliver trans-specific healthcare as well as general healthcare, and the more of the community are involved in healthcare, the better and more inclusive that healthcare will become. And also some of that trans-specific healthcare, I know again we're not supposed to, we're not due to cover that, but it's delivered by certainly a lot of psychologists, even at the GIC, but at some of the pilot projects, these are kind of health advocates and people who don't have, one of the shiny badge professions, but they still do a fantastic job in supporting trans people through different parts of the transition pathway. They help make decisions around hormones, around access to other healthcare, and it's invaluable, I think, to someone of that community to recognise themselves in the healthcare that's being delivered to them.
Thank you, everyone, for all your contributions today. We have just a couple of bits of formal business we need to, before I can bang the gavel to close the meeting. Can I ask members to note the report and subsequent discussion and delegate authority to me as chair in consultation with party group lead members to agree any output from this discussion?
Noted.
Thank you. And can I ask the committee to note the work programme?
Noted.
And the next meeting of the committee is scheduled for Thursday, the 13th of January 2022 at 10 a.m. And there are no items of urgent business. I declare this meeting closed.
Right.
Thank you, both of you online.